Hello, thank you for introduction. I'm Hyun from Bucheon Sejong Hospital. I'm going to present a patient who underwent ventricular assist device implantation for Fontan failure, who is struggling for life until now. I have some concerns about the presentation because this case is not typical Fontan failure patient. So the discussion could be distracted from the main issue with Fontan failure. Anyway, let me start. The patient is 30-year-old male. His initial diagnosis was DIRV, DORV, mild PS, huge in left VSD, and mitral valve straddling and right anterior aorta. Let me summarize his complicated medical history. He received Bucheon procedure at the age of 3 months. Then, at 13 months old, BCPS and both PA angioplasty were performed. But unfortunately, the vessel became stenotic soon, so SBC and LPA angioplasty should be done again. Nevertheless, the LPA continued to be hypoplastic, and balloon angioplasty was needed after 1 year. At the time of LPA angioplasty, left upper pulmonary artery was already sacrificed. LPA balloon angioplasty was performed successfully. The patient could not undergo Fontan procedure because of high risk from poor LPA bed. He was transiently followed at other hospitals during this period and received right axillary fistula creation at the age of 8 for augmentation of pulmonary blood flow. After he returned to our hospital, he put a stent in the stenotic LPA. These angiograms are showing LPA stent insertion procedure, like this. However, the stent was not sufficient to increase the LPA blood flow. Finally, the physicians decided to perform supergland procedure, which included proximal LPA occlusion and central shunt implantation between ascending aorta and LPA. As you can see, here is a new implanted central shunt that runs long tortuous course. This hemodynamic data is obtained during cardiac cath in 2013. SVC and pulmonary artery pressure was 220, and ventricular EDP was also elevated up to 18. These high pulmonary artery pressure and VEDP are the obstacles to perform Fontan procedure. Lastly, in 2020, additional balloon angioplasty was done for the central shunt and LPA stent due to their progressive stenosis. Now let's go back to the current admission. He showed progression of cyanosis and dyspnea. He also complained generalized edema and severely decreased exercise capacity. His oxygen saturation was around 70 under nasal prong O2 3 liter, and hemoglobin and hematocrit were also high, and BU and NT-proBNP were high. Creatinine also was relatively high considering his low lymphoid mass. Actually, he was 163 centimeter and 40 kilogram. Echocardiography showed mild ventricular dysfunction and moderate AVVR, but AVVR DPDT was more than 1,000. The ejection fraction of ventricles were also borderline, with mild decreased longitudinal strains. Chest CT angiography revealed total occlusion of central shunt and left pulmonary artery by thrombosis. On the first day, we performed the cardiac catheterization for thrombectomy. On the first day, we can recanalize central shunt and the proximal LPA via mechanical thrombectomy using angiojet system. On the second day, a balloon angioplasty and additional three stents insertion were performed, and the patency was recovered like this. After the procedure, his oxygen saturation rose to 80s on high flow support, But unfortunately, at that night, SDH, SH, and ICH developed. He underwent emergency craniotomy and evacuation of a hematoma. And after 4 days, he suffered from another neurosurgery because of aggravation of brain edema. He could be stabilized soon and transferred to general ward after several days. He was given cranioplasty in 2 months. In spite of stable, simple procedure, he gradually developed edema and orthopnea and dyspnea after surgery. He had an echocardiography that demonstrated progressive ventricular dysfunction. The physician in charge described several heart failure medications serially. These are the images taken when the heart failure symptoms aggravated. Ventricular contractility decreased a little and trachea regurgitation worsened. TRDPDT decreased to 700. The ejection fraction and longitudinal strains also decreased. Serial X-rays reflect clinical course of the patient. Left one is the image at the time of admission. And prominent pulmonary congestion and cardiomegaly can be detected. The middle one was taken just before initiation of new heart failure medications. After 1 month of medical treatment for the heart failure, the X-ray image got better, like this. The congestion improved significantly. Of course, the echocardiography also showed improvement. TR decreased a little and myocardial performance slightly improved. He used the rest of hospital days for weaning the IV medications. He discharged taking multiple medications after 3 months of hospital stay. However, his clinical status at discharge was not good. The functional status was 4, and oxygen saturation was only 65% at room air. And cystatin C and NT-proBNP were still high. Eventually, he was readmitted 3 days after discharge. We discussed the case at the conference. Doctors in charge agreed on the idea that he needs addition of pulmonary blood flow and support for dysfunctional ventricle, and someday his heart should be transplanted. However, staying in wait list was not an attractive option to majority because a patient in Entermax Profile 3 or prior to status 2 in Korean organ allocation system has to wait for a donor heart for more than several months to years. And his strong and high PRA levels required high-intensity desensitization procedure and may lead to transplantation failure from rejection. So we decided to perform ventricular assist device implantation as BTT or BTD and perform one of the upper two options depending on the situation in the operating room. The first option was 1.5 repair and LVAD support, and second option was Fontan completion and LVAD support. On the operating day, the surgeon consumed the whole working hours for dissection. There is no exaggeration. Several days after the dissecting day, the main procedure can be performed. He could undergo these procedures as we discussed. The surgeon did Fontan completion because of the high complexity of intracardial anatomy and broad straddling of the mitral valve. At the end of the surgery, temporary ventricular assist device was implanted to support the weak ventricle. At this point, the reason why the surgeon used temporary VAD instead of durable one is that it was the condition of the VAD approval committee. That is, they wanted us to prove VAD implantation was possible. Post-operative course was not easy but acceptable. On the following day, he needed bleeding control surgery and experienced extubation failure, but he could be extubated POD6. His vital sign was maintained within the optimal level on new Fontan hemodynamic under temporary VAD support. Then we decided to perform durable VAD implantation surgery. The post-operative course was also tough, and the extubation failure could not be overcome because of diaphragm palsy. He got tracheostomy and home ventilator was applied. These CT images were taken 1 month after the Fontan surgery. You can see the Fontan conduit like this, and the HeartMate 3 pump is here. However, the story still goes on without happy ending until now. Only 1 week after transfer to general ward, he developed facial edema and neck swelling. Even seizure developed after additional 2 days. Attending doctor performed portable sono and detected significant thrombus in SVC. And fenestration became smaller. He was transferred to ICU again. Altiplase infusion was given to the patient for several hours cautiously. Then cardiac cath for thrombectomy and fenestration widening was done, but pulmonary hemorrhage developed during the fenestration selection, so the procedure ended prematurely, and ECMO was inserted due to the profound hypoxia. Although he eventually could be weaned from the ECMO and underwent fenestration widening, central venous pressure was persistently high, so we gave him additional cardiac cath procedure for embolization of collateral vessels. Here is the vital sheet just before retransfer to general ward. You can see, as you can see, the CVP was significantly and persistently high between 25 to 30. As you can expect, his Fontan failure symptoms such as edema, ascites, pulmonary hemorrhage recurred only 2 weeks after transfer to general ward. He repeatedly transferred to ICU and even underwent implantation of covered stents in both subclavian arteries to address abundant AP collaterals. However, central venous hypertension and systemic congestion were not resolved. He became dependent on hemodialysis to control the edema and ascites. Although we tried to convert CRIT to intermittent HD, the trial was not successful because of poorly controllable ventral venous hypertension, edema, and ascites, and hypercalcemia. Then we tried to give relatively high blood flow pumping via CRIT. These are serial X-ray of the patient on the day of transfer to ward and retransfer to ICU and after covered stent implantation. And you can see the last X-ray, which was taken after CRIT blood flow rate increase looked better compared to previous ones. Up to now, the patient is still stays in ICU expecting approval of durable RVAD addition. Fortunately, the extracorporeal durable RVAD, that is Berlin Heart score, was approved to be used in adult patients older than 18 years recently. We hope the patient to get the opportunity of RVAD implantation before taking the risk of heart transplantation. Thank you for your attention.